So just by the way of introduction, I'm going to start off, you know, the connection seems to be put there. Is an age-old friend. I've known him for just under 40 years, I guess. Thereabouts. I've known him since 1985. Let's say thereabouts. And we were in medical school together. We were both classmates.
That's right.
And he was the smartest in the class and the youngest. And you know, he used to make the rest of us look like we were as it were behind him. And by the grace of God, he's been consistent in what he does, and now he's a professor of you know, infectious medicine, and he's the chief of the division of infectious diseases at the Feinberg School of Medicine in Northwestern University, Chicago. Okay, and he has so many accolades to his name. His area of specialty is primarily, you know, HIV/AIDS, and you know, there's so many things he's doing under that remit. Do you want to tell us a bit about what it is you do in terms of you know, your work, very briefly, in the area of infectious diseases? Just in a few seconds, if that's okay.
Yeah. Well, number one, I'm a practicing doctor.
Yes.
So I still see patients with a lot of infectious diseases, but I also am involved in research, particularly HIV/AIDS in the United States and also in Nigeria, and also in training and education of medical students, fellows, etc.
Oh, excellent. So, I mean, this is just to build context. Prof, do you have anything else on? Because there's a bit of an echo. Is there? Do you have any other?
Yes.
Phone or anything?
Let me get rid of all these other devices.
Okay. All right. I think it's better now. Okay. Cool. So, I've spoken with other people over the last week or two, you know, as regards the pandemic. I've spoken with a doctor here, a young doctor who's on the front lines dealing with the issues in his hospital. They have about 440 patients, 240 beds are COVID patients. I spoke a couple of days ago with a doctor in New Jersey, you know, and also we got the situation in New Jersey and in the US. But I believe you are best suited to talk about the disease because this is your particular area, you know. So let's start by talking about COVID-19 as you know it. Just very quickly, a quick summary, you know, and your experience with it so far.
Well, COVID-19 is an infection that the world has never seen before. The first question is, where did COVID-19 come from? COVID-19 came from coronavirus 2019, and that was summarized to COVID-19. It's caused by a novel coronavirus that we all know started in China. And before it got into humans, it was in bats, we believe. And by some strange coincidence of changes in both the bats and in humans and exposure to the virus, it acquired the capacity to infect people. Remember that viruses that live in animals typically are not able to infect humans. So we can cohabitate, etc., but it wouldn't infect humans. Something has to change for a virus to achieve that ability, and this particular SARS-CoV-2 was able to do that. And not only was it able to infect people, it achieved the ability to spread from one person to another. And so we now have this pandemic that we're dealing with.
And so, I mean, good thing that you actually mentioned the thing about bats, because I was listening, you know, to the news today, and another professor was being asked this question, but I wasn't quite fully satisfied with what I had. He did a good job, but essentially, how did that transmission happen from bats to humans? You know, because is it that the bat beats a human being, or the man ate the bat? Did the bat try to eat a human, or did the human?
No, it's actually not that complicated. It's basically the virus came into contact with humans, which has always happened before. And in this case, it happened in a marketplace in China. We think that there are popular marketplaces where people interact with different animals, and the virus was in contact with humans. But the question is, why did this virus that normally shouldn't be able to infect humans, why was it able to infect humans? And for that to occur, a number of things happened. One, there's a particular protein that humans have on their cells, or that the virus uses to enter cells. It's called ACE2 protein. That protein, the way it was normally configured, really didn't allow this particular coronavirus to infect humans. But the ACE2 protein changed a little bit in humans, which is a natural thing. Our proteins are always changing. And then the protein in the bags also changed in a little way. And for some reason, this situation where the changes in the virus and the changes in humans sort of match is a sort of perfect storm that could not have been imagined or concocted by even a mad scientist. That is why when people say that, it came out of a Chinese lab, you really have to question that, because it's not something that if you wanted to create a potent lethal virus, this is not what you will do. It's not a logical sequence of events. So it's a little not mysterious, but a little interesting that this perfect storm of changes in the bad virus and the humans happened to enable the bad virus to infect humans.
It's a great thing you also mentioned about the whole theory that, it was created in the lab, because that has been going around, and there's a lot of propaganda to that effect. Okay, what would you also say to the whole 5G thing? Because that is a big thing where there's a whole group of people who believe that, look, there's no such thing as a COVID-19 virus, and that it is actually caused by 5G, and that the whole symptoms that people feel, blah, 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 is fine. So tell me about the medical science of it. Is that possible that radiation can cause this kind of effect in humans?
No, absolutely not. This has been debunked by the World Health Organization. If it were normal times, this sort of speculation would not even make it into the news. But we are in strange times where all kinds of speculations are being broadcast. But to your question, there's really no way for this to be a 5G-induced thing. We know the virus, we know the protein, it can be seen under the microscope, we know how it produces. There's no mystery about the virus. We understand a lot about it. And the 5G thing should be totally thrown out of the window.
Okay, but in more specifics, people are saying, I want you to look at the whole possibility or debunk it from a science viewpoint. Is it possible for radiation to cause such flu-like symptoms in human beings on a mass scale, and also
no, it's not. No, it is not. And I will use a very simple, I'll try to use a simple explanation, which is that we know that if you had COVID and you came to visit me in Chicago, and we spend time eating together and we exchange and shake hands, you might contract COVID from me.
Yes.
If this was caused by radiation, it would have to be that you brought the radiation all the way from the UK. And you somehow had the radiation in your hands and you shocked me and transferred the radiation to me. So the natural life cycle of this infection, what we know about how it spread and the infections and the conditions it causes, really does not support any idea that it's caused by radiation.
Okay, so of all the various, we've had various viruses over the years, from Ebola to, in recent times, to the bird flu and the other strains. Why has this particular virus been particularly rapid in its spread? And, why is it so pathogenic or supposedly deadly? What would you say about that?
I heard the first part is why is it so rapid in its spread?
Yes.
Right. And the second part was why is it so?
Why is it so? I mean, deadly. When I say deadly,
right?
bird flu and the other strains that we saw earlier in the last few years didn't spread this fast, neither did it kill this many people. At least we did not see a pandemic, a worldwide epidemic. It was kind of more localized. So what would you say to that?
Well, many things. One, we've never seen this particular coronavirus before. So if you think about the flu, every year the flu goes around. And there are little changes in the virus that causes, we have a new strain, but it's not as if the human race has not seen this flu before. So maybe we have a little bit of immunity that's already in our body. And also the virus itself, if you take the bird flu, for example, it's certainly not as infectious as the one that we're dealing with now. So it's a combination of the virus that we have now being more infectious, right? And also being more pathogenic, meaning if you have it in a human being, interestingly, it affects not just the lungs. This ACE2 receptors that the virus binds to is in so many different organs. It's in fat cells, it is in the kidneys, it's in the brain, some of it is in the heart. And now we know that the effects of COVID really is not localized to the lung. The lung is sort of the theater, is the main stage. But virtually every organ is affected. We have people coming with blood clots, people coming with heart attacks, people coming with strokes, people come with kidney failure, liver injury. Just because of the way it enters the human cell. This ACE2 receptors that in a lot of places. And of course, it does one thing that not all viruses do so potently, which is it makes all these cytokines, which are things that we normally make as a part of our defense mechanism to ward off infections. So when the body is attacked by, let's say, a new infection, your body just doesn't sit there. Your body tries to do something. One of the things your body will do is to make these cytokines. But for some reason, the cytokine response that we see with this virus is excessive. It's several tens or hundreds fold higher than what you would expect. And it's a double-edged sword that you make so much of it that it begins to damage critical organs
in the body. And we also have seen that, like, in recent times they say it affects black and ethnic minorities more. Here, especially in England, there was something that was said a few days ago that in the NHS, I think out of 10, I'm yet to be I can be corrected on this. Out of 10 doctors that have died, maybe 6 or 7 of them were either black, or from an ethnic group. Why is this a racist virus, or what exactly? I mean, why is it more lethal in that particular group?
Right. So I'm certain that the virus itself does not discriminate. So we have to try to understand why is it that this epidemiologic thing that you described is the same in the United States. In the US, it's really not the physician population that's been studied like that. It's in the general population. So amongst people who've had COVID and had bad consequences, including death from it, it's really concentrated amongst African Americans. And the first question is it a genetic thing? Right. If it were genetic, you would expect that COVID in Africa should be behaving differently. That when patients have infection in Africa, they should be sicker, etc. We're not seeing that. So it's very unlikely that it's a genetically determined thing. In America, it is quite likely that it's not different from what we see with high blood pressure, diabetes, strokes, cancer. Pretty much every clinical condition that you can think of is worse in manifestation and also more common amongst African Americans. And so this is really an extension of long-standing disparities in healthcare outcomes, which you can tie to healthcare access and also to baseline or pre-existing conditions. So if you had Mr. A and Mr. B who become infected with COVID, Mr. A might do poorly if he has high blood pressure, diabetes, heart disease, kidney disease, pre-existing. In America as a whole, blacks have those things more than other races. So the risk factors that predict poor outcomes concentrate amongst blacks. So it's not as if the virus is doing something new. It's a combination of pre-existing inequalities in access to care and pre-existing excess amounts of bad conditions that make COVID worse in African Americans, like diabetes, hypertension, heart disease, kidney disease, and so on and so forth.
So does it make sense that based on what you just said, that if 6 to 7 out of 10 deaths are among Black and ethnic minority medical professionals, is probably because they have a greater propensity towards high blood pressure, diabetes,
heart disease, kidney disease? That's a likely explanation. But before we reach that, that's probably true. The other thing is you have to look at the number of Black doctors who were exposed compared to number of non-Black doctors who were exposed. Right? So if you're looking at if the infection was concentrated in Black communities, Black communities tend to have Black doctors. More than white doctors. So we have to make sure we're comparing apples and oranges. I think if you had a Black doctor and a white doctor in a room and we're the same except for their color, then I would say that there will be no difference in the likelihood of them being infected and dying. But when you now...
sorry to butt in, our good friend and colleague, Dr. Zeze Makinde, just asked a question right now. I mean, just to give everybody else a background, we are all colleagues from the same class, graduates of UCH, College of Medicine, the best medical school in Africa. The 1991 year. I think I was D88. Were you C or D group?
No, I was B. Zeze was C, I think.
Yeah, so Zeze was C. So Zeze just asked, what is the correlation between vitamin D and COVID?
So there's a lot of speculation that vitamin D or sunlight and all those things can have an interaction with COVID. The answer is, think about it. We've only known about COVID for about 4 months.
Yes.
So to make a categorical statement about vitamin D and COVID in that period, when we've spent all the time looking for ways to treat patients, is really quite speculative. So I would just say that we don't know enough. I don't know. I've seen convincing associations between vitamin D or vitamin C or zinc and COVID to be able to say specific things about that.
Okay, 2 things. First of all, let me acknowledge Dr. Adeotoye is also on. He says there may be other factors amongst medics, as in dose of exposure and all of that. And then somebody else just asked, please, why is it that COVID-19 shares similar features of malaria symptoms?
Well, that's very straightforward, because the symptoms that many infections present with, they're really not the infection causing it. They're the body's response to the infection. So the fever that you have, the running nose, all these things, they are things that will come as a result of those cytokines and other similar proteins that the body makes. So if you're infected with malaria, your body responds the same way. If you're infected with the flu, your body will do the same. If it is this new virus, the response is the same. That's why one cannot use symptoms alone to say that Mr. A or Mrs. B has COVID. You really have to do the test. So many conditions present with exactly the same symptoms, although over time we're getting smarter and we can say that, oh, this particular thing is likely to be more common in this particular patient than this other one. But overall, it's because there's a common path through which infections affect the body.
Okay. Interesting. Also on that same line, I mean, we just spoke about how COVID seems to be affecting more Black and ethnic minority people here in the UK and let's say in the Western Hemisphere. But we don't see in Africa, the spread is not as profound. And there was one time that people were saying, oh, that it can't spread in Africa because of the sun, or there was some kind of association between okay, yes. So somebody else is saying, okay, in Kenya is saying, what explains the low penetration in sub-Saharan Africa?
This is a very interesting thing, and right now there are many theories that are going on that people are thinking about, and I'll try to say some of them. The first one is the genetic thing. Could it be that Black Africans somehow have genetic protection against it? That is unlikely to be the case because, as you just said, Blacks here, although Blacks in America and UK are not the same as Blacks in Africa, we know Blacks in the UK and US are doing worse. So it's probably not genetic. No one has done the critical test to know if that is the case or not, but I suspect it's not genetics. Next is it the environment? Maybe is it the sunlight that's killing the virus and making it less likely to be transmitted? There are all kinds of speculation in that regard. Again, no one has proven it. So I will put that in the maybe category, unproven. Maybe, but I'll say maybe because we don't know. The third one is it possible that Blacks or Africans have been exposed to viruses that are similar to this particular coronavirus, and so have built up a certain level of immunity, and so when the body sees this new virus, it's not a totally new thing compared to some of the more protected, in quote, parts of the world. That is something that only science can reveal, and in fact, we are trying to look into that. We're collecting blood from Lagos, Abuja, and Ibadan. We bring them to bring the samples here and ask that question: do patients who have never had COVID, do they have some sort of proteins in their blood that will suggest some pre-existing protection against this? And could it be luck? Right? I don't think that luck alone can explain what we're seeing. It's more likely that there may be some pre-existing immunity, maybe some environmental things. But whatever it is, I think as an African and as Africans, we should be really glad that it's not spreading as it did in New York City. Because you can imagine if you had the same degree of spread in Lagos or Kano or some of the even more, the less privileged parts of the country, the northeast corners of Nigeria, we will be in serious trouble. But so far, so good.
Some have gone as far as saying that COVID-19 is a disease of the affluent, that maybe that is why it hasn't spread as much in Africa. So,
I can imagine those kinds of speculations, but I think the initial people who got it in Africa were people who brought it from their travels to the US and to Europe, and so these were relatively privileged people. It was not the man or woman minding their business in the remote corner of Nigeria or in Ibadan or somewhere, not jetting around the world. And so if you look at the people who were initially infected, they were people from the high class of society. And there are many examples of that. But we know now that there are people becoming infected. I'm in very close contact with some of our colleagues at the University of Ibadan, some of whom we went to school together, and others outside our class. And people are getting infected. The security officers, etc., who are not the affluent getting infected. But again, it's really not the same rate. And the severity of the disease is certainly not the same. Imagine here at Northwestern, we have, I don't know, I think probably almost 50 people on ventilators, etc. Wow. There aren't people on ventilators for COVID at the University of Ibadan. And so even if people are becoming infected, the severity certainly is not this, does not appear. Does not. I think we have to be careful. About exactly what I say, the absence of real data, but it's not making the news, right? We're not hearing that people are dying in Ibadan and we have ventilators potentially out of supply. We're not hearing that. Something is quite interesting and profound, and it would be nice to look at it more carefully.
Dr. Zeze is asking, what should we expect, in the future in Nigeria and in Africa regarding the COVID thing? Do you think it would not be as prolific as it has been here?
Yeah, if we're using just the experience to date. So if we say that COVID got into New York on, let's say, on this date, and a month after that, how many cases were seen? 2 months after that, how many cases were seen? And you ask the same question in Nigeria, COVID got into Nigeria on this date. How many cases have been recorded? How many deaths? The trajectories have been quite different. So if we use that metric, one can expect that it's not going to be as bad. We've heard a lot of there's truth to the saying that people are not being tested in Nigeria. But well, if people are not being tested, that's because they're not sick. It's just right. If you had a lot of people sick at the same time, they are not just going to sit at home and die. They would go to the hospital, and it would be in the Sketch or Tribune or something. We're just not having that kind of mass reports of a lot of illness. And fingers crossed, I hope things don't change. But so far, so good. There are new cases being diagnosed every day, but just not what one would have predicted. Ibadan, for example, does not have a real lockdown. Ibadan has curfew from 7 p.m. or so to 6 a.m. or something like that. But in between, people are moving around. And
they're not seeing an increase in...
and they're not seeing an explosion. They're not seeing an explosion of cases. If you tried that in Chicago a month ago, we would probably have had, I don't know, 5-10 times the number of infections that we have now. Right? So it actually took a total shelter in place to control. Look at New York City. People have been in their apartments for 6 weeks now. Nobody out. Which is not what's happening in Ibadan. But
and it's still
yesterday there were over 1,000 new cases. Was it 1,000 new cases? More than that, actually.
About 1,200 cases. 1,000 deaths.
No, new cases diagnosed. There were 430 something deaths yesterday. 430 deaths in New York yesterday. So
a number of people have also been asking, someone from Kenya and a few others, what about hydroxychloroquine and other such drugs in the use of the treatment? Well,
so hydroxychloroquine has been used for or tried for many other infections before. This is not the first time that it will be pulled out to say, okay, and why are people pulling it out? 2 reasons. Number one is that it really does do something, affect the viruses in a way that should make the virus less likely to survive. That's one. Number two is that maybe it can affect the immune system too. That's why it's used for lupus, for example, because it can affect the immune system. I remember I said that this virus does 2 things. It can cause infection, can also affect the body's response to things. So it's being used a lot. And the question that you have to ask is, what is the evidence that's behind that? If you look in the literature or newspapers, there's not one single, very well done, large study in which some patients were given hydroxychloroquine and other patients were given placebo to tell us whether the drug is effective. The only way you can really know if a drug is really effective is to do that. So a trial where some people get the dummy drug, some people get the real drug, you follow them, you see who does well. That has not happened. It's happening now. Results will start coming out in a few weeks. So what we really have are cases where somebody will say, okay, I gave 300 patients this drug. So and they did better than when I didn't use the drug. And those kinds of results, they're good, but they're not perfect. So we have to go back to what they taught us in medical school, which is first do no harm. So the FDA, for example, will say, well, you can use hydroxychloroquine, but number one thing is don't harm a patient. You can harm a patient if the patient has pre-existing heart conditions, if they're old and they're taking medications that interact with hydroxychloroquine. And I think that is the first. If anybody wants to prescribe hydroxychloroquine or any patient is prescribed hydroxychloroquine, ask your prescriber, is this safe for me? Do I have a condition that might make me at risk of suffering complications like the heart? That's the main thing. It can affect electrical activity of the heart and predispose to cardiac arrest in some people. But if someone does not have pre-existing heart problems, they don't have diabetes, or they're not taking medications that can cause problems, then the likelihood of being harmed is very, very low. And in that situation, the doctor and patient can say, okay, rather than wait, maybe we can use this drug. But no doctor should tell a patient that I am sure this drug will cure you. because the evidence just does not exist.
It's not there.
It's just not there. It may be there in a few weeks. It's just not there today. But first thing is do no harm.
What about your, I mean, because you had said at an earlier date about a doctor colleague who apparently contracted COVID and then supposedly used it, and is more or less sure. What would you say about that?
Right. Well, there are many anecdotes. We call those anecdotes, right? Where a patient, someone will say, well, I started taking the medication and within a few hours or a few days, my fever went away. I became well.
Yes.
That is true for that person, but I can also tell you somebody else who we prescribed hydroxychloroquine to in the hospital, and after 3 days was intubated and remained and still on the ventilator. So you really don't know whether that patient, that doctor improved because of the drug or not. Maybe
Yes.
it did, maybe it didn't. So that's why we really have to focus on safety, right? Because the worst thing you can do is give a drug to somebody that won't help them, but then you hurt them.
And it kills them.
So it kills them. So if it is safe and the patient understands and the doctor knows what they're doing, I have no problem with somebody prescribing hydroxychloroquine until we have the evidence, right? The other alternative is just to say, I'll do nothing. But maybe that's the right answer sometimes. And in fact, some of my colleagues do that. They would not prescribe hydroxychloroquine except it is in the context of a clinical study. And some of us who are from Africa will say, well, I know that this study will not happen in Nigeria for a very long time.
Yeah.
So am I there to say that I will not do anything for a long time? And we try to balance the two. And in my mind, the first thing is first do no harm. If I can convince myself that this patient is not going to be harmed, and then there's nothing else for me to do, and the patient is willing, I will tell them, I don't have proof this will work. But if you're willing to take it, please go ahead. The other good thing to note is that it is sometimes co-prescribed with a drug called azithromycin.
Yes.
And that came from France because somebody put them together and said, oh, this combination kills the virus more than hydroxychloroquine by itself. Well, the issue, though, is that when you use them together, the alteration in the heart's electrical activity that I talked about earlier on is actually worse when you use them together. So combining them together is even more, that is when the potential harm goes higher. And it's really, I would do that only in a clinical trial or if a person is in the hospital, because there's really no proof that it will work. And you don't want to hurt somebody.
Someone just asked, I mean, there are two questions I'll ask in quick succession. Someone just asked that could there be a correlation between the low states of COVID incidents we're seeing in Africa with the fact that perhaps there's been, profound use of malaria drugs and malaria prophylaxis over the years? Could there be that correlation?
No. Because the reason is when you take malaria drugs, the drug will stay in your system. Hydroxychloroquine actually, interestingly, if you take it for a week, it will be in your blood for up to a month. Right. So if you took it for malaria a year ago, there's no hydroxychloroquine in your body today. And there's no way it's going to protect you from the person that's shaking your hand who has COVID in their hands and the coronavirus on their hands. The body is not changed by hydroxychloroquine. When you take it, it works while you're taking it. Once you stop taking it, after a few weeks, it leaves your body. And so there's really no way that will be the case.
Okay. So somebody else asked that ventilators seem to be the supposed lifesaver when we get to the critical stage. There's a shortage of ventilators around the world, even in rich Western countries. Are there any alternatives to, the critical state, intervention?
Yes.
To
well, desperate times call for desperate measures, and sometimes creativity explodes during this sort of period. Number one is in the United States, people thought we're going to be out of ventilators, etc. That has really not materialized. I think the US is sending ventilators to other places now because there was a time when a lot of work was put into making ventilators. But to the point about alternatives, there are many things that one can do before a patient gets to ventilation. First, you can use oxygen just through nasal prongs, and then the amount of oxygen can be increased. It's called high flow oxygen, and that can be delivered through a variety of mechanisms. Sometimes even the CPAP machine that is used for sleep apnea, which is just a way that you force oxygen into the airway, that can be tried as well. But ventilation is actually something that you do. It's an end-stage thing, and it's without ventilation, some patients don't make it, and actually most patients who die in the US die while they're on the ventilator.
Yeah,
it's rare that.
In the hospital in the UK, they've been found that that machine that has been used to treat sleep apnea, they've actually converted it, and it has shown to reduce the mortality rate in that particular hospital.
Yes, that's a good point. People are doing that. They're using the CPAP machine. They're using it as ventilators. Even a device was created to allow patients share ventilators, to use the same ventilator for 2 people. But it hasn't gone forward because the need never materialized. So should there be a need for that, even those kinds of creative approaches will be possible.
So someone else asked that, I need to see the question again, but that after having COVID and being tested as positive, does the person remain infectious afterwards?
If someone is infected, you shed virus the most when you're sickest. So when that person has fever that's high and they're coughing, that's when they're shedding the most virus. That's when they're most infectious. When they recover, the amount of virus that they're producing goes down, but it doesn't go away immediately. In general, it takes about a week after the symptoms have stopped for you to really have low levels of shedding. But most people continue to shed virus through about 2-3 weeks afterwards. And we now, if somebody has been diagnosed with COVID in the hospital, we use 40 days as the time point that we think that the virus should be gone. Because a large study done in China that looked at patients who were infected and continued to check them closely found some people who were still shedding virus 37 days after the infection was diagnosed.
Wow.
So that seems to be the outer period. So here, if you've had the infection and we don't see you, we label you actually in the hospital as a COVID patient. So if you show up in the hospital, there's a red flag on your name. Somebody will say, oh, you had COVID. Yes. Now that flag falls off after 40 days. So 40 days, we automatically assume that you've been cleared, except you fall into one of a few categories, one of which is patients who have a weak immune system. So if somebody has a weak immune system, either because they're on treatment for cancer, or whether they've had transplantation and they're receiving medicines, to steroids or other things that suppress their immune system, those people, they may continue to shed even beyond 37 days. Wow. And in those patients, we require that they have 2 samples checked, 2 samples that are negative, at least 1 day apart, before we can say, okay, this person is cleared. So shedding continues for some time.
Okay, let me ask 2 questions in one for sake of time. The first is, I'll ask this one about reinfection, but please answer that second. Let's answer this one. Would Prof advocate that everyone should wear face masks whenever they are out? Will this protect others and also prevent spread of the infection?
Well, it depends on a number of things. Number one is, what is the infection level in your locale? If you're in New York City or you're in downtown Chicago, where we know the infection rates have been high, then not only do you protect other people, if you're going to a place where you cannot maintain social distancing, that is the first thing. It becomes very important. And the mask will help you to protect yourself, but in case you have COVID, it will protect other people. So in Chicago, for example, it's required that you wear a mask if you're going to a public place. Okay. Now, if you have a big house or you have a neighborhood where you can walk and there's nobody around you, nobody will force you to put on a mask there. But it depends on how much COVID is going on in your area. If there's a significant amount of COVID, then, and you're going to a place where that is public, where you can either give COVID or get COVID, then it is advisable to wear a mask. But if the incidence is very, very low in your area, or you're not, you're just by yourself and you're surrounded, separated by miles from the next person, then it's not as important.
Okay. Someone else, there's quite an elaborate question here. It said there's been talk of using an oximeter to check your oxygen levels. How does this help in safeguarding or alert one to COVID? Is that helpful at all?
Well, if you don't have COVID, it's not helpful at all.
At all.
Yeah, if you have COVID, what happens many times is somebody has symptoms suggestive of COVID, but they're not able to be tested, either because the test is not available or somebody is telling them just stay at home, don't come, and they know they are sick. Well, the way COVID kills most people is through the lungs. And so if there's a way to monitor the oxygen saturation in that situation, it might tell you whether you're actually doing okay or doing worse. But someone who's not sick has really no reason to be checking their oxygen saturation. But if someone is sick and think they might have COVID or they have confirmed COVID, knowing your saturation might be useful. But I don't think it's that readily available to be able to use commonly like that.
Why? Okay. What about the issue of reinfection? The number of people have asked that. Okay, I didn't see your question. Sorry. What can you rewrite it? Okay. What about it? Is it possible for a person who has had COVID, to later on be reinfected?
There have been reports of that in Korea. So the answer is yes, it is possible, but it is not usual. And I think that it will be the exception, not the rule. It's going to be rather rare. And that's because once you are infected, in most cases, you develop some kind of immunity. We just don't know enough about the immunity that people develop. And we don't know whether it is what's called protective immunity, which means you are so immune, you can face this virus again, nothing is going to happen to you. We know some viruses do that. If you've had, say, hepatitis B and you have a certain level of proteins in your blood, I can expose you to hepatitis B, it won't do anything to you. If you'd had measles before and you had high titers, nothing's going to happen to you. But we don't know enough about this virus to say whether the immunity that people have is protective completely. And if it's protective, it probably won't be the same for everybody. People who are older, the older you are, the less likely it is that your body will produce enough of those protective proteins. So a young person who's 13 or 14 might get it and develop this protective immunity, but an 80-year-old person who also has diabetes and is taking all these medications might have it and not develop protective immunity. So the best thing is really to just still remain very careful, because washing your hands, avoiding touching your mouth, ear, nose, and face, and things like that will protect you not just from this COVID virus, but also from the flu, which we know will come for sure, and a myriad of other viral infections and other infections that we all are exposed to on a daily basis. Okay, good. There's a political question which I meant to ask, but I'll ask that at the end. But so I want to ask, somebody told me today and sent me the link from Metro Life here in the UK, which is a notable news agency, that they say that there are 30 new variants of the COVID-19, and the deadliest are supposedly in Europe. So what about, is it true that there has been mutation, for us lay people, as the virus changed in its form and is coming in a more lethal way, Yeah, right. Every virus undergoes mutation on almost a daily basis. So when viruses try to make little babies and reproduce and make copies of themselves, they just want to make copies of themselves. They don't care how accurate it is. So mistakes keep happening in how they assemble the proteins. Those are called mutations, changes from what it was before. So those things happen. Oftentimes when they happen, they just die off because they're not really effective. There is really no evidence that a more lethal kind of COVID is going around now. If you look at the COVID in Chicago, some of our colleagues have said that, well, it came from Shanghai. You can trace where it came from. You can trace where the one in Washington or London came from. But to say that this virus is particularly more deadly than this other one, I think that is premature. And we're in an environment where a lot of news, sensational news in particular, gets circulated really fast. And we have to take a moment to know exactly what we're talking about.
Very, very, very accurate. So, based on your own experience and estimation, it's obviously a new virus, 4 months or so, you know, old, unprecedented times. The whole lockdown thing, people are worried, they're concerned. How long do you think this will go on for? I mean, here in the UK, there are speculations that, well, it can go for as long as till the end of the year. Some say maybe 2 years. You know,
right.
Realistically, well, what do you think?
Well, a woman in, I think it was Kenya, I was reading a few days ago, said, if death is death, if you die from COVID or you die from hunger, you know, death is death. And so, if you think about that, I don't think that people can keep this for too long. From a scientific standpoint, we know that many of the countries, many of the states where this started months ago, they are getting close to or they have reached their peak. Even New York City has started to come down, right? I said 430-something people died in New York City, but last week it was 700 and something on a daily basis, or 800 and something. So then it's coming down. That is what will happen in most places. But how long, your question was, how long do I think this will go on? I think in several weeks, people will start opening things up here and there. There's some states in the US, like some parts of, I think it's Wyoming or something, where the rate is very low and the local government, they don't have a lot of cases. They're going to try to open things up a little bit, see what happens. I think over the next few weeks, certainly over the next few months, those kinds of things will happen. I'm hopeful. I think that we all need a little bit of hope during this time. And I hope that when things are warmer, not that I think that just because of the COVID it's killed by sunlight. I hope, because all viruses tend to have this cyclical pattern. Even the flu tends to have this cyclical pattern, that when things are warmer, that things will improve. I don't know if that will be the case. We just have to wait and see. But I think that in the next few months, things should get better, for sure. It doesn't mean that COVID will disappear from this planet. In fact, I think it will be around. We may see COVID again next year and maybe the year after, but it should never shock us as it did this time. Because by then, a lot of people that have been exposed, a small look in New York showed that maybe 20% of New Yorkers were exposed. And if we happen to have a vaccine and we can vaccinate people against it, it will be a different battleground compared to what we have now. So I think that I'm hopeful that in the next few months, things will open. I don't think it's a year-long lockdown.
What about, somebody just said something about when we go to the supermarket? That's a very important one. Or, you know, should we disinfect, you know, all that we get from the supermarket? When we get something in the post, do we disinfect it? Then with that, also, how long does it last on a surface? You know?
Okay. Yeah, the last question has actually been looked at.
Okay.
And we know that it can last up to about 72 hours on some surfaces.
Yeah.
Some surfaces will last about 48 hours, so 2 to 3 days on a surface. Yeah. And when it's expelled in hair, it can last maybe 72 up about 3 hours in when you exhale it or when you cough it up, basically. When you go to the supermarket, if you're in an area where COVID is common, then it's wise to wipe the trolley that you're going to be using. Right, you don't really lose anything, and of course, don't ingest the disinfectant. Don't inject it. Don't ingest it. But you certainly should wipe. And most supermarkets now make those wipes readily available. Certainly in the US, certainly in UK. May not be the case in Ibadan or Lagos.
Yes.
Maybe it's in Lagos actually. Maybe it's in Ibadan. We shouldn't underestimate our our country folks.
And then two things. Somebody had mentioned something about the possible, apart from droplets, a possible aerosol effect that, you know, maybe with the aerosol effect that it may stay longer, possibly in the air. Is that a possibility?
It's possible. It's not common. Certainly, some scientists have done good work that suggests that it can be that way. The initial guidelines was based on the premise that when you cough it up, it's actually spread through aerosols. That's the way it's spread.
Okay.
But then that if you have a distance of 6 feet, aerosols can travel up to 6 feet or 2 meters, and then they will generally just fall down. But there have been cases where they've generated these aerosols and found that they can actually travel further than that. But in general, the social distancing of 6 feet or 6 meters is because we think that when you cough up and generate these particles and they're carried, within 6 feet, they just don't stay suspended in the air. But we know that within the 6 feet, they can be suspended for several hours. So if I had a patient with COVID in a room and they leave that room, I'll leave that room closed for 3 hours before letting another person go in without a mask. So,
wow, that's an interesting one. What about someone also said something about there seems to be some kind of correlation between the virus load, the amount of virus that is released, and also the severity of the illness. Hence,
yes, that is true.
Yes. So maybe that's why more doctors are maybe dying, maybe because they are closer to the patients or whatever. What will you say about that?
Well, I don't know that is necessarily true. Okay. Because I'm sure there are doctors who've been exposed and never got infected, right? Yes. There'll be large serologic studies now to look at the blood of doctors, frontline workers, and I'm sure we'll find people who've been exposed time and time again, but they've not been infected. In fact, it may be that by being exposed multiple times, you may be the one who's more likely to become immune because you get small doses at different times. So I wouldn't say that it's not possible. I'll say that it's just not, we just don't know. One other important point, though, is that there's a whole group of people who are called asymptomatic people. Symptomatic people are those that you described. They're coughing, they sneeze, they're coughing, they have fever, they have diarrhea, things like that. That's symptomatic. Another category of people, they have no symptoms whatsoever. We know that these people also shed the virus, and that most of the transmission, well, maybe not most, a lot of the transmission occur from people who don't even know they're infected because they're not sick. And they're out with their friends saying, oh, no, I'm fine. I don't have COVID. And the friends say, yeah, you look good. You're not having fever. But in fact, they have asymptomatic infection. And we know that those people shed virus as much as people who have the symptoms. And so that is why social distancing is so critical, because you cannot tell who has the infection and who's not infected.
Okay, so if one of the major determinants about whether one has COVID or survives it is based on an individual's immunity, how can we build our immunity? So that we prepare. Because
I think, yes, the things that have been shown over the eons to help preserve and boost the immune response to things are the things we are all, they're gifts to us, like sleep. Sleep is a big one, number one. Two, exercise.
Wow.
It's been shown to, and just good nutrition, eating foods that are nutritious, not junk food. Those three things play a big role in determining the body's response to all kinds of assaults, including infections.
It's like you're preaching to me, Prof.
but we're always looking for, but not you, we're all guilty of not being perfect in those areas. Yeah. So we're always looking for shortcuts. Yeah. Can I take vitamin C? Can I take zinc? Can I take vitamin D? And so on and so on.
Yes.
Again, I go back to my premise of first do no harm. I don't see how vitamin C, unless you overdose yourself, can hurt somebody. And I don't see how zinc, unless you overdose, can hurt somebody. So if you want to take it, Godspeed. It's really just, if you want to take those things, okay, but don't do that and not try at least your best to observe those other really fundamental things that have been shown over the years to improve health. Try to sleep, try to eat well, try to exercise, and leave the rest to nature.
God will help me with those three. But I mean, we have about 3 minutes to go, so let's just address some quick things, which are the political climate in America is very different from the rest of the world, and it seems like there's a lot of there's the federal politics and then there's the state politics. Do you think there's what's the word I'm looking for? That political interest is superseding health and safety at this time?
Yeah. Unfortunately, there will be presidential elections in November, as well as infection in the House of Rep. So whether we like it or not, it's a political season, and politicians they're on the loose. And I don't think there's any doubt that what people are doing and how they're posturing is influenced to some extent by considerations of the underlying politics. That's why if you listen to a certain news channel, you will hear things that really are always in support of the presidency. And if you listen to another channel, they are always against the presidency. So it's very difficult in the climate. I think that there's a lot of political undertone to many of what we're seeing. And science is really struggling to survive and find oxygen. The other thing that's polluted the environment is just the media. Every news item is now polluted with things that in normal times, people who conduct science would not give it a few minutes of thought. But you just read it on pages of newspapers and people believe them. It's very unfortunate.
I mean, our time is counting down. It will shut down in a few minutes. I want to first of all thank you, just in case the time cuts off. Prof, you've done a phenomenal job. But you know what you've done for me? You've actually, stirred up my appetite for medicine again. Almost 30 years on. If my dad was around, he would, if he heard this, he would say, "You see, Shola, you should have stayed in medicine." Interestingly, one of the things I wanted to do was epidemiology. Yeah, apart from neurology, epidemiology, and he would have said, and you would have been able to help in COVID. But I think I'm helping better with prayer. And
I think I agree with that completely.
And with things like this. Yes.
Yes. This is great. I was going to say that. So well said.
So, but on the last note, last few seconds, if you can tell us about vaccines, it's going to cut off in 50 seconds. But
I think vaccines are critical. Yes. The world needs vaccines. Studies are just being conducted, and we all wait to see the results. We need vaccines desperately.
Okay, and how long do you think it will take to develop that?
Well, the whole process from developing what might work, testing it in a few people for safety, then testing in more people for safety and efficacy, and then mass producing it always takes months. I don't see how we can have a vaccine available for routine use in less than a year.
Thank you so very much. We really appreciate you. For those of you who are online, watch out. In another few days, I'm going to bring on the person in charge for public health for the whole of Canada in another day or two. Thank you, Prof.